outstanding work and insights. So we've now asked for a presentation from the author of that radiology study that I mentioned from April, Nina Brandstack from the University of Turku. She's done a study entitled Quantitative Diffusion-Tensor Tractography Can Depict Post-Traumatic Abnormalities Not Found at Conventional MRI. So, please.
Thank you. Good morning, everyone, and thank you, Professor Vannier, for inviting me. I think it's a great pleasure to present our recent study in this very interesting and important workshop. This short presentation is mainly based on this our recent study published in Radiology on April. As we all know, in the acute management of a traumatic brain injury patient, CT is routinely the first imaging method since it can be performed rapidly, and pathology that is critical for the early medical management of cerebral trauma can be detected by CT. However, MRI is superior to CT in the detection of intraparenchymal traumatic lesions, and traumatic brain injury often leads to persistent symptoms even in cases without findings in conventional MRI. Especially in such cases, it might be difficult for the clinician to decide if the symptoms are due to true injury or some other disorder. Accurate and early diagnosis has influence on the effectiveness of the chosen treatment. And as many traumatic brain injuries occur in traffic accidents, work-related accidents, sports-related injuries, or assaults, their medico-legal consequences may also be significant. We studied 106 consecutive clinical subjects with traumatic brain injury without any abnormalities on any like trauma-related abnormalities on routine MRI, and 62 demographically matched control subjects. DTA at 3 Tesla was performed for all with Philips Medical Systems and 2 excitations, 15 gradient encoding directions, which we thought that were enough because all those tracts we studied were relatively large and were based on prior knowledge. Deterministic diffusion-tensor tractography was performed by using an fractional anisotropy threshold of 0.15 and a turning angle threshold of 27 degrees to terminate the tracking process. The tracts were defined with 2 to 3 freehand inclusion rows and from 1 to 4 exclusion rows depending on the tract. We studied several association tracks on both sides, and volume, ADC or mean diffusivity, and fractional anisotropy of the tracks were measured. We studied superior longitudinal fasciculus, in inferior fronto-occipital fasciculus, which is blue there, and uncinate fasciculus temporal superior and temporal cingulum, and arcuate fasciculus, which is yellow, and inferior longitudinal fasciculus. Statistical analyses were based on repeated measures analysis of covariance. We took sex, age, time between injury and imaging, trauma mechanism, and severity of traumatic brain injury were considered as covariates of the tests. And time between injury and imaging for all the patients was 3 or more months. We found that in controls, tract volumes showed large variability, while FA and ADC values showed small variability. In several tracts, mean FA values correlated negatively with the respective volumes. And in subjects with traumatic brain injury, FA values were reduced in both unguinate fasciculi, both inferior frontooccipital fasciculi, and in the right inferior longitudinal fasciculus compared with controls. Diffusivity was increased in half of the tracts. The tract volumes were not significantly reduced, which may be due to that we had mainly quite mildly injured patients and because in controls also tract volumes showed large variability. I shortly introduce some additional reproducibility results that has not been yet published except for in my dissertation, which had public defense a few weeks ago. But in this reproducibility study, inter-rater and intra-rater reliabilities was assessed by both the intraclass correlation coefficients and planned Altman reliability analysis. And the tractography was performed using 2 different FA and turning angle thresholds for each tract to evaluate whether the lower FA and higher turning angle threshold decrease the reproducibility. We also did volume-based FA and ADC analysis in the central part of the tract with 2 predetermined sizes. And example of those is from the one tract superior cingulum is presented in that picture. We found that for the tract-based methods, intra-rater and inter-rater reliabilities of FA and ADC measurements were all excellent. Between scan reproducibility was good or excellent in most of the measurements. In that study we have had relatively few subjects, and in our study neither the turning angle threshold nor FA threshold had a systematic influence on reproducibility. As conclusions, quantitative diffusion tensor tractography is able to show post-traumatic FA and ADC abnormalities in subjects with normal routine MRI in several association tracts, most commonly in the unguinate fasciculus. In our study, with most of the patients Glasgow outcome scale between 5 and 7, we did not found any correlation FA decline and outcome, which was actually expected because outcome for all the patients was quite similar. The tract-based FA and ADC measurements, according to our study, are highly reproducible, but the large variability of normal tract volumes and the dependence of mean FA values on volume can decrease the accuracy of the method. Thank you for attention and greetings from Finnish Midsummer.